This is Tim Short, Associate Professor in Palliative Medicine at the University of Virginia, talking about breaking bad news. This is a topic that's really important and very common for both primary care providers as well as specialty providers. You will probably, in your course of your career, have a need and an opportunity to provide people with difficult news. But as this cartoon depicts, there's another way. You could, as this says, there's no easy way I can tell you this, so I'm sending you to someone who can. Unfortunately, a lot of times we're not able to do that, and we're faced with sharing news with our patients and families. I'm going to be utilizing the Spike's 6-step protocol for delivering bad news, a validated approach among many experts developed by Dr. Bailey and Buckman and their group. The goal of the Spikes protocol is to enable the clinician to fulfill the four most important objectives of the interview disclosing bad news. This will break down to gathering the information from the patient and their understanding of information, transmitting the medical information in a meaningful and sensitive way while providing support to the patient and family, and then together collaborating in developing a strategy or treatment approach as to where to go from there. I want to stress that this procedure of breaking bad news, I liken it to a surgical procedure. When it's done well, it can really offer healing and hope. When it's done poorly, it can really cause harm and unintended injury to the patient and family. It can lead to a misunderstanding of the disease or the prognosis. It can lead to misunderstanding of the goals of treatment. And it can really isolate the patient in their treatment planning. So it's a very, very important skill to have. I think it's really important to talk about what is bad news. And bad news is any information which adversely and seriously affects an individual's view of his or her future. Bad news is always in the eye of the beholder, and the impact and the gravity of the news is not only determined by the clinical information, but it's shaped also by the patient's expectations. Very important concept. So if we look at some examples of bad news, I think all of us would agree that getting a diagnosis of an inoperable cancer would be considered to be bad news, as would a newly diagnosed advanced cardiomyopathy or advanced pulmonary disease. I think we'd also agree that if we were given the news of a progressive neurologic disease, we'd consider that bad news. Some of us might consider a positive herpes simplex culture to be bad news. Some of us might not. I think in the eye of the beholder is what's really important. So if this news was given to someone that it's really going to impact their relationship with their loved one, it could be terrible, devastating news. Likewise, advanced knee osteoarthritis in an elderly person might not be terrible in one individual. I'll get it fixed, I'll move on. But to a gentleman who's the primary caregiver for his wife with advanced dementia, it could be really devastating news. So we have to look at the clinical perspective and the outlook of the patient. So let's look at this 6-step strategy for breaking bad news. Here's the mnemonic for Spikes that's utilized, and we'll go through that one step at a time. The first step is setting up the interview. Some people use a newer mnemonic, P Spikes, the P standing for planning, and I think before you even create this structure around the meeting, planning is really important. What I mean by that is you really need to know the results, the details of the results, what they mean, and if you need to check in with a specialist, etc. You should have all of that organized before stuttering into a meeting with a patient and family that's serious like this and not really having your ducks in a row. Also, before you go into this meeting, I think it's really important to be aware of your own feelings. As this slide indicates, delivering bad news is sad, it's hard, it's stressful, And for this reason, I really like to do this with another member of the healthcare team. I often have my nurse come in with me. That gives you also somebody else to get a read on the patient and family, to support them, and also to support you on the other side of this meeting. The physical setting is really important. You need to arrange for privacy. You need to make sure the right people are there, the people that the patient would want. And I really would encourage you to sit down. These meetings are much better when you convey the message that you're there and you have all the time in the world. You need to connect with the patient by listening and connect with them emotionally and sometimes physically by touch when appropriate. You need to make sure that you're not going to be interrupted during this important meeting. The next step is assessing the patient's perception. And the underlying axiom here is before you tell, ask. And here we go back to our open-ended question that we all learned in the beginning of medical school that got drilled out of us in our residency and further training. But to go back to a question such as, can you tell me your understanding of your condition or your understanding of why we did that CT, that CAT scan, and see where they go with that. That allows you to get the patient's level of understanding, whether they got the information correct, and how they're coping with that. Are they dealing with denial or wishful thinking or blocking out parts of it, and do they have unrealistic or realistic expectations? The next step is to obtain the patient's invitation. And what we mean by that is, how do you want us to relate information? Do you want to know all the details? Or do you just want to know the big picture? Do you want me to share the details with your family and just give you the big picture? I wouldn't make assumptions because sometimes patients don't want to know details because it's just going to cause angst, and they'll give you permission to share those with family. So ask before you make assumptions. That way the patient can control the flow of information, and then you really have to be careful about the pace of the conversation to make sure that they're in sync with you. That brings us to the fourth step, which is really the heart of this meeting, giving knowledge and information to the patient. This is where I think you really need to be sensitive and to be listening to the patient's words and aware of their body language. I like to, and the experts recommend, giving a warning shot, a shot across the bow, so to speak, so that we warn them that bad news is coming, with a statement something like, I'm sorry the CAT scan findings showed some bad news. And then there's a pause, because your next sentence is really critical. Now, you can do this in a way such as, I'm sorry that the CAT scan showed some bad news. There's a mass in your pancreas and I think it might be cancer. And if you can blur it all together, you're lost. Or you can do it with this technique, which is, I'm sorry that the CAT scan findings showed some bad news. We saw a mass on the pancreas, and I'm concerned that it could be cancer. The pause, the timing, the tone of your voice is really important, and that also gives you space and time to gauge their response. Because if their response is emotional and overwhelmed, you need to stop there. You can't go on. It's really important in this part of the encounter not to use medical language. It's one of the reasons we started with the open-ended question. You can get, by listening to their understanding, you can get an understanding of their level of language that you need to speak. So you use their language. You want to avoid excessive bluntness, but you want to be absolutely clear. And you want to give them information in small pieces and then check in, such as, I'm afraid that this showed a mass on your pancreas and I'm concerned that it might be cancer. Do you understand what I'm saying? Now, we don't know that for sure that it's cancer, and I think we need to do some more tests to know for certain. I'm going to send you to a specialist. Are you with me? So checking in to make sure that they're listening is really, really important, particularly when a prognosis is poor. And remember, even when the prognosis is poor, there's always care to offer. The next step, step 5, is addressing the patient's emotions with empathic responses. I've already touched on this. If there's an emotional response, as there often can be, it really needs to be dealt with before you can move forward. That emotional response can be anger, crying, denial, disbelief. It can be all over the map. And you need to stay there and deal with it because you're not going to make any progress until you do. The best way to deal with emotional responses are with empathic responses. Look for them, be sensitive, anticipate them, and when you encounter them, naming it is often a first step to try to get control of it. If you're not sure, you can ask. You seem to be really upset. How are you? What are you feeling? What's going on there? Or identifying the reason for the emotion and connecting that statement that show that you're with them. I know this isn't what you wanted to hear. I wish the news were better. As I said, until an emotion is cleared, you won't be able to go forward in the conversation. When you talk to patients and families on the other side of these difficult conversations, they will all emphasize how important it is to have experienced and empathic and validating statements like we just discussed. And then the sixth step is strategy and summary. This is where we transition to asking the patient about where do we go from here. And I think you need to gauge patients and families, first of all, to see if they're ready for that. Ask them, do you want to talk about a treatment plan? And if they say, no, I got to get my head around this, then you can schedule it in the near future. If they say, yes, what do we do here? Then you clarify their understanding, and before and it might sound something like this. Before we go on, let me just check with you again. Can you tell me what your understanding of this conversation is, so that we start on the same page, and then I'll talk about what our options are going forward. Understanding the patient's specific goals will help you frame hope in what is possible to accomplish, and hope in a future. You'll be able to step with them into the future, as what's most important to patients at these times is that they're not alone. And secondly, that they are in control of what they're going to encounter in the medical system. And thirdly, they're going to be comfortable. They're not going to suffer. These are what are most important to patients and families when they're confronted with a serious illness. And by using this SPIKES protocol, you can take the first and most critical step towards that.